And for the 11th installment, what we're going to talk about is AV blocks or AV dysrhythmias. So these usually happen at the level of the AV node or at the bundle of His. And we're going to kind of cover the four main types that we see and maybe when we would see them and when we won't. But understand it's not an all-inclusive list, okay? So we can actually see the first is a type 1. So the type 1 AV block is going to be a PR interval greater than 0.20 seconds, but with no subsequent dropping of the QRS complex. So these ECGs often enough elude providers, these AV blocks often enough elude providers because there is a P for every QRS, there's a QRS for every T. The only problem is the PR interval is greater than 0.20 seconds. Now this can be a completely benign finding in a very athletic or a very young person, or it can be a signal that something bigger is coming on. It can also be a pathologic process with degradation of the conduction system, which will later on lead to more problems. But generally, by and large, the first degree AV block does not cause a huge problem in your patient's stability. It may be a warning sign something else is coming, but it's not necessarily one of those things that is going to make your patient become unstable all at one time. Now, the second degree type 1 AV block, which is also known as the Winky Balk, is a bit of a different story. We don't usually see Winky Balks without some sort of significant pathology. It's not usually something that a completely stable patient without any disease process just spontaneously develops. So the reason it's called a Winky Balk is because it involves the Winky Balk phenomenon. And what that is the PR interval will gradually lengthen until you drop a QRS complex, until you have a standalone P wave with no QRS complex there. And this has led to sort of the sing-songy nursery rhyme of longer drop. That's what we call Winky Balk. And it's a nice little moniker that helps you remember things. So when the PR interval lengthens until you have a dropped complex, this is a second degree type 1 AV block, which is commonly known as a Mobitz 1 or a Winky Balk. Now, moving forward, you have a second degree type 2 AV block, which is often referred to as a Mobitz 2. Now, this is an intermittent block. The P waves, the PR interval does not lengthen, nor does it shorten. It remains almost constant. It remains normal, so to speak, in some cases. And you just have what appears to be a randomly dropped QRS complex. One feature of the second degree type 2 is that they are often regularly irregular. So often enough with a second degree type 2, you'll have every fourth beat dropped, every third beat dropped, every fifth beat dropped. So you'll have a normal PR interval, it will not be lengthening, and then all of a sudden you will just drop a complex. You'll have a P wave that's perfect, there's nothing wrong with it, the morphology is the same, and then you just have a dropped complex there. That's going to be a second degree type 2. Now you can actually see compromised cardiac output with these. It depends on how many complexes are dropped and how often. It also depends on the patient's state of cardiac output when this happens. These often enough can also show up in a right coronary artery infarction. So when you see an inferior wall MI, conduction disturbances such as this are also common. That's something you kind of want to keep an eye on. You can also see the third degree AV block, which is almost a complete divorce of the atria and ventricles. That's usually how I hear it summed up. So generally what happens is the P waves march out with a regular P to P interval, and you will see ventricular complexes, which can be narrow or wide, and they will march out, but they will not have anything to do with each other. So you can see P waves that are hidden between ventricular complexes. You can see different types of things that go wrong. But when you sit down with a set of calipers or a ruler and you measure the P to P interval, they're regular. And you measure the R to R interval, it's regular. But the two do not seem to have anything to do with each other. The P wave is not influencing when a QRS fires, and that is actually the third degree AV blocks. And this is common in the elderly. It's common in different disease processes, especially long-standing cardiac disease that causes ischemia. It is also common in the right coronary artery infarct. So when you see someone who has an inferior wall MI, often enough that is the right coronary artery that's blocked. The RCA infuses the entirety of the conduction system, so you can see this in there. It is very often compromised or comprised of poor cardiac output. So you can see patients that have a very low blood pressure. You can see patients that are unable to perfuse in normal realms. And when this happens, generally the ventricular rate will be bradycardic, and you treat it just like you would a sinus bradycardia with electricity. So when I say just like it, that's probably a poor choice of words. You don't use atropine on these patients. Atropine is a parasympatholytic that is going to decrease vagal tone and cause the sinoatrial node to fire faster. Given that the sinoatrial node has no effect on the ventricles because there's a complete block at the AV node, atropine isn't going to do anything to help your patient, but it can hurt. It can cause the patient to have paradoxic bradycardia, especially in your pediatric patients. So one of the things to remember with this is that a third-degree AV block with signs of poor perfusion generally will require transcutaneous pacing. So they'll need you to put your pacer pads on. And just to quickly review that, you click the pace button, you set your rate at 60, whatever your treatment modalities, whatever your protocols are, and then you will dial up the milliamperage until you achieve electrical capture, and then you will palpate for a pulse and dial up the milliamperage further until you achieve mechanical capture, meaning you feel a pulse every time the pacer fires. And that is generally how you treat the third degree AV block. We will cut this one short and separate it so we can talk about junctional rhythms and keep these arrhythmias separate in their categories so people can go back and study individual ones. Thanks for listening.